So Dr. Hashmukh Sir is our first speaker. So let me have an honor and privilege to introduce him. He is MBBS MD, ACME FISH, Professor of Physiology at Dr. M.K. Shah Medical College, Chandkheda, Ahmedabad. He is one of my best friend. My senior, we had our undergraduate together. He is Chairman Student Council, Bhaikaka University 2024, and multiple awards and academic excellence on his name. So without wasting much time, let's talk about insulinization for India. Let me have 1 more minute talking about this project, that despite of having maximum number of diabetic population in our country, we are delaying insulinization for more than 6 years. And that years are very crucial because patient may develop macro and microvascular complication and further quality of life is hampered. Not only quality of life is affected, but economical burden on the patient's family as well as country is raising. So we have to do insulinization at proper time. Also, not only starting insulin is sufficient, we have to intensify and keep HbA1c below 7. So that is very, very important. So to further highlight this thing, let us hear Dr. Hashmukh Shah, sir. Over to you.
Thank you, Dr. Vipul, for kind introduction, and Dr. Dhruvi madam for inviting me. And really, I'm speaking on very IMP topic on insulinization of India. So why there is a insulin therapy matters? So what is the need? So normally it is very easy to introduce or to give treatment of various type of the deficiency disorder. So when you're suffering from any deficiency, insulin, iron, iodine, so very easy. But in most of the cases, they are the oral things we are giving. But in case of the insulin, we're not able to give the oral treatment. So here for insulin, we have to give the injections. So one of the critical thing, because Indian patient, as per the Indian culture, we are not able to take or we are not able to consume anything in form of the injection. So our first choice is the oral tablets or oral material, oral preparation, any syrup, tablets, like that. So here it is really difficult to convince our patient for the injection. So why there is need to give the insulin. So here because for the better management of the glucose, mainly we have to maintain the proper glucose homeostasis. So for survival, as Joshi sir mentioned, insulin as well as glucose, their main role as it is anti-aging. For survival, for proper growth of life, we have to give the insulin. So here, mainly for the proper glycemic control, whether type 1 or type 2 patient, we have to give the insulin to prevent the complication. It is maybe microvascular or macrovascular complication. And for the long-term proper management of the diabetes. And there are so many misconceptions regarding the insulin. So here, why there are clinicians are hesitate to give the insulin. So here, because of these so many misconceptions, there are so related to hypoglycemia. So it associated with the so many complications. There are fears, lack of confidence. So here in primary care setting, physicians are not proper trained. They're not attending conferences. There is no proper training. So here they have fear. And as well as we have to give the proper assurance to our patient. So that's why in primary care setting, fear, lack of confidence, so many misconceptions are there. So that's why they are not giving the insulin properly. So when to initiate the insulin? So here normally when patient blood sugar remains high, persistently high, because maybe type 1, there is no choice in type 1, but in case of the type 2, when sugar level continuously high despite of the oral hypoglycemic drugs. So here we have to give the insulin when it goes more than 130 mg and HbA1c more than 8. Ideally we have to start the insulin. And another things, though we are on treatment, oral drugs, and symptoms are saying that sugar is not properly maintained, all these things, polyphasia, polyuria, polydipsia. So here in this condition we have to start the insulin. In some cases in acute condition. So here in acute condition, diabetic ketoacidosis, we do not have any choice. We have to start the insulin in case of some special condition, pregnancy induced, as well as in case of the surgical. Okay, prior to the surgery, as a pre-op preparation, we have to give the insulin, but mainly in acute condition, mainly in case of the diabetic hyperosmolar coma, we have to start the insulin. So what happen if we delay the treatment? So here normally in any treatment, okay, intervention is required. So if we have choice to start with the oral drugs or insulin, if we are not going to start the drugs properly at one time, we do not have any choice. So here it is better to start the early rather than the late. So why? Because of the proper control, rapid control, as well as for the beta cell preservation. So here in case of the type 1 patient, look here that in diagram, one child is playing. So here if we start the early insulin, so here we can have the proper control, as well as we are going to reduce the glucotoxicity. So that's why in case of the type, as we do not have choice, there are so many restraints from the family issues, Indian culture issue. We are not ready to accept these things. But as we do not have choice and we want the proper control, as well as in case of the beta cell preservation. Early when we have type 1 in few patients, so many patients, there are preservation of few cells. So here by starting initial insulin, we are going to preserve the beta cell rather than we are going to completely dependent on the insulin. So here in this way, we are going to delay the progression of the disease, and we can have the delayed insulin initiation. Here there are prolonged periods of the hyperglycemia. We are going to prevent the prolonged hyperglycemia. Along with these things, we are going to have reduce the irreversible damage. So here mainly the vascular and microvascular as well as macrovascular complication we are going to delay. So what are the common barriers and myths related to the insulin initiation? So one is the fear of the injection. So patient fear the injection. In India, we are not ready to take any injection. And when it is needed acutely, just example is the tetanus injection. Though we have any injury, it is compulsory, mandatory we have to take the injection, but people have fear that they are not ready for the injection. So here fear of the injection, and there are in community we see lots of the complication associated with the injection, insulin. We do not have proper physician or proper trained nurse that give the proper injection on the proper site. So it is associated with the abscess, so many complication related to the injection. This is the main thing. Another thing is the weight gain. People, community, they have fear that by taking the injection, we are going to have the weight gain. But this is also myth. We have to explain. We give the assurance to our patient. Weight gain is mainly when we are not taking insulin. Weight gain is there. So if we take the insulin, we have the proper weight control as well as we have the proper growth. So insulin is one of the growth factor. Insulin is the hormone of the growth family. So when we are taking the insulin, we have the proper growth. And all the people of the diabetic community, they know very well insulin as well as thyroid, growth hormone, IGF-1, 2. So as a factor of the growth family, along with the sleep, as Dr. Vipul sir told, okay, sleep is also one part of the growth family. So what are the practical challenges? As I talk, so your local lack of the confidence as well as social stigma are associated with the insulin. So here proper patient resistance is there as well as proper counseling is needed. So assurance is given to patient, malpatient along with the family. We have to educate the family and how to overcome the barrier. So we give the confidence, okay, to our patient. We demonstrate the injection, how to take the injection. This is one of the good thing. And nowadays, our diabetes community, they are giving the proper education to the patient, how to give the injection. Lots of websites are there, apps are there, how to give injection for the injection site, techniques. YouTube is flooded with so many videos. So nowadays it is very easy, but counseling is needed. So we have to come forward to take the injection. So demonstration of the injection is the must, and we give the why we have to give. So here benefit with the contraindication. So here we give them these are the benefits of the insulin. So benefits are mainly more as compared to the contraindications. Now, how we give these things? So building the provider confidence. So mainly we give the education to the primary care physician. because they have to attend the training programs, and insulin is not associated with the any complication. So here we give them, it is going to help for the prevention of the macro as well as microvascular complication in the long term. Weight management, we have to give them, assure that weight management is proper by giving the insulin. And what are the step-by-step approach for the insulin? So here, initially we start with the education of the patient as well as family and reassurance. So we give the reassurance that there are no chances of the any complication of the insulin. So education of the patient is must, and this is the first step. Along with the training of the primary care physician here, at the same time training of the patient as well as family is needed. So how to initiate the insulin? So here initially we start with the basal insulin, and then we have to titrate the dose. So initially we are on the somehow check and error phase. So when we give this thing, so here initially we give the confidence to the patient, and we have to start with the basal insulin. And what are the various type of the insulin? As we know, glargine, determine, degludec. So these are the suitable basal needs of the insulin. Then we give the prandial insulin, premix insulin. So these are the alternative options. For the beginning, we have to start with the basal regime only for the initial beginners, and later on after this we start with the basal bolus combination for the proper glucose maintenance and the glucose homeostasis. So here we have to educate the primary care physician as well as our patient regarding the rapid acting insulin, rapid short acting, intermediate acting, and the long acting as well as ultra long acting insulin. So here we give the knowledge. This is the mainly must thing when we have to take the immediate rapid acting insulin, when we have to take the long acting insulin. So we have to show them with the time, and this is the mainly needed. At what time insulin is going to act, we have to take before, how many minutes before the diet, any meal we have to take the insulin, how much amount of insulin is needed before the breakfast, before the lunch, before the dinner, and we have to give them the practical tips. So initially they are facing issue within the 1 week or 1 month, but later on patient are able to manage their sugar level. So here we have to give them, start with the low dose. Initially we are going to begin with the 10 units of the insulin, then adjust the gradual over the week of the time. We are going to take the fasting blood sugar records. So here in this way we have to maintain our blood sugar level within the range 80 to 130. So practically as per the CGM and the insulin pump, we have to manage within the 70 to 180 range. We are not going below the 70, not above the 180 renal threshold level, that we are going to protect our kidney. And in this way, we are going to protect from the cardiorenal diseases, because here the entry of glucose into the glucose to the kidneys without the insulin. So here our first step is to protect our kidneys, then liver, lungs, as well as our brain. So initially we have to educate our patient about the managing the hypoglycemia. So here there are fear of two-side fear, hypoglycemia as well as hyperglycemia. Always we have to remain within the normal range. It is not easy. It is not easy to remain within the 70 to 180 range. So here education is needed. And one more thing is the continuous monitoring is needed. Because previously we are giving in the morning insulin, one insulin at the dinner. Okay, nowadays we have to monitor. If you want the proper control, if you want the proper time in range, okay, more than 75%, if you want the proper control of the sugar within the range, proper glucose homeostasis, so we have to check the glucose sugar regularly. So continuous glucose monitoring. And nowadays we have good resources are available for the continuous glucose monitoring. Libre as well as Medtronic devices are available. And so here we have to manage the sugar properly, and in these events we are able to manage the sugar properly. We are going to have proper control, because to give insulin after some time very easy, but sugar monitoring, so many people, patients, they are not monitoring sugar. They are monitoring on Sunday or maybe after 3 months. So many old people, they monitor after 1 year. Even they have fear of the investigation. Fear is also there. So continuous glucose monitoring is need of time, and we have to adhere to the treatment. So family involvement, because mainly in case of the all metabolic diseases, hypertension, diabetes, kidney disease, liver disease, adherence is poor. If you show the data, in Indian context, only 20% adherence is there, adherence to the treatments. 1 out of 5 people are adhered to the diabetic and hypertensive treatment. So that's why for the proper adherence, support of the family is needed, support of the physician is needed, along with the lifestyle integration. So here, proper monitoring and follow-up is required. So here, as I told, proper blood sugar check, HbA1c check is needed, dose adjustment is needed, and again we have to watch for the complication. Because why we have to do? Because we have to live the healthy life. So here, for proper regular health checkup is needed. And that is the one concept is totally missing in India, that is the annual health checkup. In most of the patient, even doctors, when we see them, okay, their blood pressure is very high, they are pre-diabetic, pre-hypertensive, so they do not check their own blood sugar, high blood pressure regularly. So here, we have to check our sugar, our pressure regularly, and we have to watch for the complication of our patient. One more thing of the injection of the insulin is the hypoglycemia. So here we have to recognize the symptom of the hypoglycemia by the awareness of the patient, and be ready with the glucose to prevent the hypoglycemia. So we have to set the alert when the sugar goes down from 100, 90, 80 and 70. So here at one stage we have to stop these things, and we have to give the insulin. Only 1 minute. So here, this is the role of the primary care physician. So here we have to initiate the insulin early, give the assurance to our patient, dose titration is needed, and we have to manage the side effect. What are the common pitfall? Okay, so here we have to avoid the aggressive titration. Initially start with the low dose and check the regular sugar, and then move or increase dose one by one. And education of the patient is needed along with the regular follow-up, and we have to overcome the fear of the complication. So here, lots of information is available through the mobile app as well as through the website. We have to run so many support network is needed for the families. So many community programs are going on. We have to take the advantage of that thing, and we have to assure our patient that insulin is safe, and so there is no side effect is available with the associated with the insulin. So here, education of the patient involvement is needed. Once you are going to involve, you have the better outcomes. So here, for the better outcomes, regular follow-up is needed, continuous glucose monitoring is needed, and this is the chart of the patient involvement. So I stop here. Thank you.
Thank you so much, sir. And most of the time we talk about the clinicians' inertia, but most of the time there is a inertia from psychological part as well. We are not investing enough time to educate patient about taking insulin. Most of the time what I used to practice is I tell my patient that you have no problem with insulin. I have written 5-6 tablets, you are taking them without knowing what is in it. But you have problem with needle. You know insulin is the base therapy for you at this point of time, and there will be a time that we will decrease the dose or we will make you off insulin as well. But you have phobia for needle, and to have better control of diabetes, better benefits because of insulin, you have to take this 1 or 2 needles per day, and that is why patient get agree on that point. So wonderful talk, sir. I have a round of applause for Dr. Hashmukh, sir. Yeah.
Thank you. Thank you for giving opportunity.